I assume everyone can hear me and see my screen. Just as I was announced, I'm Brock, and I'll be presenting on my project titled Evaluation of Suprascapular Nerve Anatomy and its Relevance to the Effective Suprascapular Nerve Blocks, a morphometric cadaveric study. So let's get into it. Um, so here are just a few terms and abbreviations that will be on the presentation for you to familiarize yourself with. I'll give you just a second to read over them, and let's move on. So getting into some general information about the suprascapular nerve and where it lives. There are a lot of anatomists here in the room with us, so I don't want to bore you guys, but a little bit of review is always good, especially for me with boards coming up. So the suprascapular nerve originates from C5, C6 nerve roots of the superior trunk of this brachial plexus, passing from the axilla and traversing posteriorly through the suprascapular notch to supply the supraspinatus and infraspinatus muscles. It sends sensory branches toward the glenohumeral joint, where it provides approximately 70% of the sensory innervation of that articulation. As you can imagine, it is a common contributor to shoulder pain, which is the reason we are focusing on it today. So shoulder pain is the third most common cause of musculoskeletal pain, with a prevalence of about 20% in individuals over 65, affecting women more frequently than men. Shoulder pain is a common complaint and causes pain, and the causes of the pain include osteoarthritis, rotator cuff tears, labral injuries, as well as a lot of other minor aches and pains when you get older. Treatment options range from conservative approaches such as physical therapy, anti-inflammatory medications, and steroid injections to surgical interventions such as shoulder arthroplasty and superior transverse scapular ligament release. So where do these nerve blocks come into all of this? Suprascapular nerve blocks can be an effective technique for managing chronic shoulder pain, but are also frequently used as perioperative analgesia for those undergoing shoulder surgery in an acute pain setting. These blocks can be used as diagnostic tools in finding and locating angry nerves to make sure that that is the correct source of pain before doing a surgery or a radiofrequency ablation therapy or peripheral nerve stimulation therapy to make sure that they're at the right spot. Another consideration for suprascapular nerve blocks is they offer an alternative to interscalene nerve blocks in perioperative cases. This is especially useful in patients with pulmonary or respiratory considerations, such as patients with COPD or lung cancer, where an incidental phrenic nerve block, or even worse, a lung puncture, could lead to much greater complications and distress. And they want to just stray away as far as that as possible, and so a safer approach is desired. A little bit of background on why we did what we did looking at the suprascapular nerve. I had a pain management rotation during my third year where my preceptor performed a ton of these blocks. He did different forms of peripheral nerve blocks as well as peripheral nerve stimulator implants. And one of the areas of interest that we discussed was the suprascapular nerve and its course through the suprascapular notch, as well as the branching behavior. He typically would use a fluoroscope for these procedures, which do not visualize the nerves. And so in order to have a better mental image, we decided to map the course and the branching. These blocks are used with a landmark-based technique, which basically means that you aim at a target, which is the nerve, which is close to an easily visualized landmark, which is the notch. So if you hit the notch, the hope is that you'll get the nerve as well, which is close to the notch. Depending on where the nerve branches relative to the notch, some of the nervous tissue may be missed if branching happens too early or the block is placed in a location that doesn't cover the entirety of the notch. I'll have a couple of figures later on that will help demonstrate and give a better idea of what that would look like on the scapula. We were also looking for nerve size difference between different demographics that may influence the dosing of local anesthetic, which would need to be used in the block. So with that backstory in mind, the objectives of our project are as follows. Inform suprascapular nerve block techniques for acute perioperative pain management and chronic refractory shoulder pain by examining the clinically relevant anatomy as it traverses the suprascapular notch. Investigate the differences in the nerve cross-sectional area between males and females to determine the appropriate dosing, and additionally, to analyze the morphology of the notch and its surrounding neurovasculature to identify anatomical variations for needle placement considerations. This increased knowledge surrounding this topic can improve efficacy and safety while performing these blocks. So for our materials and methods, we used 93 formalin embalmed cadavers, shoulders, which were dissected, and the analysis of the suprascapular notch was conducted. We measured the cross-sectional area or the cross-sectional diameter of the suprascapular nerve within the notch, as well as documented the course and the branching of the nerve relative to the ligament. The width and the depth of the notch was recorded, and we performed comparisons of these measurements and the suprascapular nerve between the donor sex, the laterality, left and right, and age, 75 and older, and 74 and younger. We used SPSS to perform our statistical analysis. Descriptive statistics were performed to determine the means, ranges, and standard deviations. Sex, laterality, and age differences were compared using one-way ANOVA testing if they met assumptions for normal distribution and equal variances as determined by a Levene's test. Chi-square and the Mann-Whitney tests were implemented for comparison of data not normally distributed. All p-values are two-tailed with an alpha less than 0.05 indicating significance. So getting into our results. Here's some figures to help visualize our findings. So first off, just to orient yourselves, this is a left scapula. Here's the spine of the scapula. Here's supraspinous fossa. Here's infraspinous fossa. This is supraspinatus reflected from medial to lateral, as well as infraspinatus reflected. So as you can see, the nerve travels here, passes under the ligament, and branches distally to the ligament and the notch. Not depicted in this are the smaller sensory branches that would continue both here and then down in infraspinatus toward the joint to provide sensory innervation for the joint. In addition, just to give you a visualization, we broke the notch into thirds, which we labeled as a medial third, middle third, and lateral third. And we categorized the nerve course through each of those thirds. And just to give you, while we're looking here, just to give you an idea of what the nerve block technique looks like, a needle is advanced from medial to lateral within the supraspinous fossa as to have this bony protection for your needle so you don't accidentally go too deep and puncture a lung. The needle is aimed toward the notch because of using fluoroscope or ultrasound. The notch is is a lot easier to visualize than the nerve tissue itself. So you use the notch to assume that that's where your needle placement is going to be. So here, where there's no proximal branching, if you aim for the notch, you can assume that hopefully you'll get good nerve coverage. But here in our next figure, we see that there is proximal branching of this nerve before it passes through the notch under the ligament. So again, same orientation, just a little bit slightly different angle. Supraspinous fossa, here's a spine. So if the needle was to be passed medial to lateral toward this notch and aimed here, maybe at the more medial aspect, there's a chance that this lateral branching of the nerve might get missed when the dose is administered, and therefore you wouldn't get the best coverage of your block, and patient might still have pain or postoperative pain. So that was the idea of why we wanted to categorize how often this branching is happening and what it looks like when it does pass through the notch. So continuing on here, a few numbers demonstrating what we found. The suprascapular nerve branched proximal to the notch in 15% of shoulders, directly at the notch in 54%, and distal to the notch in 31%. The suprascapular nerve occupied the medial third of the notch in 15%, the middle third in 59%, and the lateral third in 26% of the shoulders that we looked at. Just one more table here. The suprascapular nerve branched a mean of 1.5 millimeters from the notch. The mean depth and width of the notch was 5.8 and 7.8 millimeters respectively. And then the mean diameter of the suprascapular nerve was statistically different in males than females, with males having 2.6 millimeters and females having 2.2 millimeters. So that was an interesting aspect that we found there. So why does this matter? When physicians first started doing these procedures, they would palpate for the suprascapular notch and aim their needle based on the palpatory findings. As you can imagine, the results of this procedure may have been hit or miss. As visualization techniques have advanced, so has the efficacy and accuracy. However, visualization is still not 100% with both fluoroscope and ultrasound, and so the need for anatomical knowledge is still very much present. As I mentioned at the beginning, many times these procedures are done under fluoroscope or ultrasound, and visualization of the nerve is impossible with fluoroscope because it's pretty much just an X-ray and difficult with the ultrasound. So many clinicians rely on the bony landmark of the notch as well as the ligament, and then place their needle relative to those landmarks to trust in their anatomical knowledge that the nerve is close by. When performing these nerve blocks, the needle should be as close to the targeted nerve as possible without hitting the nerve and causing iatrogenic damage. When the local anesthetic is administered, the goal should be to cover as much of the nervous tissue as possible in order to provide the greatest relief. As we just discussed in the previous slides, according to our study, an ideal location for the needle placement would be just at the suprascapular notch, aimed in the middle third of the notch, while staying in the supraspinous fossa to have more bony protection from some type of accidental lung injury. Another consideration is the amount of local anesthetic needed for males versus females. It makes sense that larger nerves, for example, like the sciatic nerve, would require a lot more medication than a small little dainty nerve like suprascapular nerve. So in our population, where males had a statistically significant larger suprascapular nerves than females, a dosing adjustment could be considered. Although the clinical significance of this finding still needs to be determined and could be a source for future studies. Of course, our project is not without its limitations. The embalming process may alter the size, shape, and consistency of the donor anatomy, as well as age group of our population limits the generalizability, of the study to older populations. Yeah, Dr. Johnson.
I'm sorry, go ahead. I didn't mean to interrupt you. I want to wait till you're finished.
Okay, good. So it should be noted, however, that many patients who are undergoing shoulder procedures for arthritis and joint replacement tend to be of a more advanced age. So this age limitation may have most of effect when trying to be applied to young athletes with shoulder complaints. So in conclusion, increasing our knowledge of the course and behavior of the suprascapular nerve can help increase efficacy of these blocks. Keeping in mind sex difference between males and females can help cater treatment to better aid the specific patient. Thanks for joining in and listening. Open it up to questions.